All right, good evening, everyone, and welcome to Wu Yu Sensitivity Training, a Chronicle of Neurotrophic Keratitis Management with Dr. Jacob Lang. Thank you so much, Dr. Lang, for being here. Super excited to learn from you as always. And thank you to everyone joining us here tonight. Next slide. So I'm going to be your host, Dr. Elise Kramer, and I'm currently in Miami, Florida. Where are you, Dr. Lang?
I'm up on the east side of the Twin Cities. So I'm actually in Wisconsin right now, but right on the border of Minnesota and Wisconsin, if you've heard of those two states.
Beautiful. Next slide. I will introduce our awesome speaker. Dr. Jacob Lang is the Medical Director of Dry Eye Services and Director of Associated Eye Care's Ocular Disease Residency Programs. He is also adjunct clinical faculty at the Illinois College of Optometry, the Ohio State University, and at Silas University. Dr. Lang is a fellow of the American Academy of Optometry, where he currently acts as a chair of the anterior segment section. He's also vice president of the Intrepid Eye Society, a member of the American Optometric Association and the Minnesota Optometric Association. Dr. Lang received his Doctor of Optometry degree from the New England College of Optometry in Boston, Massachusetts, where he was a member of the Beta Sigma Kappa Optometric Honor Society and received several awards for excellence in patient care and contact lens expertise. Dr. Lang then completed a cornea and specialty contact lens residency in Boston, Massachusetts. Dr. Lang joined the Associated Eye Care AEC in 2006, where he specializes in cornea and ocular surface diseases, as well as therapeutic contact lenses and surgical co-management. Dr. Lang lectures regularly and has published many articles on these topics. He is also actively involved in the ongoing clinical research at AEC. It is such a treat to have you here tonight with Wu University. Thank you so much, and looking forward to hearing everything you're going to talk to us about. Thank you.
It's my pleasure, Lise. Thanks for having me, and it's an honor to be here with you all virtually to talk cornea, my favorite thing, and hopefully be able to answer some questions throughout the lecture. If I don't get to them, I'll try to get to them at the end. I'm going to try to keep that box open though too, to see if I can pick out some questions here as we move through, because being virtual, it's not as easy to interact, and I think a lot of the learning happens when we interact with each other. I also just want to apologize to Dr. Kramer for reading this whole thing. She did an awesome job, and she's good at it, but apologies for wearing her voice out from reading all that. Financial disclosures are here. All financial relationships have been mitigated. And so again, we're going to talk about sensitivity training. This is going to count for human resources credit as well as continuing education credit. The Chronicle of Neurotrophic Keratitis. Again, I'm Jacob Lang. So we're going to talk about corneas and neurotrophic keratitis will be our focus this evening. Again, thank you all for joining me. So we're going to talk about some knowledge gaps here in neurotrophic keratitis, this degenerative disease characterized by corneal sensitivity reduction, which can lead to corneal epithelial breakdown, impaired corneal healing, and all the visual implications and ocular implications that follow that. So talk about this from T to green, hopefully talk about some new things you haven't heard about, give you some tips and tricks. So let's get into it. Seeing patients, looking at eyes. Here's case for you. So just want you to kind of get an idea about these corneas, see what you think. This is a patient I saw not too long ago. See what you think. They don't have the blue cobalt on, but I think you can see there's some fluorescein action going on here. Hopefully you can appreciate there's some epithelial issues here and not a clear view of the anterior chamber or the iris. I just want you to kind of think about what you're seeing. Talk it over in your head. What do you see on the edge and the limbus? Maybe up at like 10 o'clock, 12 o'clock. What are you seeing up there? So some things just to think about as we start thinking about corneas and neurogenic or neurotrophic considerations. So giving the cornea first, and then talking about the case history, kind of doing things backwards here just to spur some thought, spur some engagement. It's a 78-year-old man. He's on 3 glaucoma meds, underwent cataract surgery in his right eye. Day 3 develops an epithelial defect that we saw on the previous slide. Treated with tears, ointment, no resolution after 5 days. This is being stubborn. Bandage contact lens placed for this epithelial defect, 5 days, no change, still persistent. Tarsorrhaphy was performed, and then the epithelial defect resolved. Talk a little bit more about that, but I think my MD colleagues really love tarsorrhaphies. I think optometry doesn't love them as much. That's my group, and that's my feeling, is I don't love them as much. I don't think patients love them very much. But even after the tarsorrhaphy, which I think you'll find very common, persistent, significant keratopathy persists, poor vision, poor visual outcome. So what's next? Well, inserted Procara, discontinued all glaucoma medications. So medication vacation is what I call that. You're on lockdown, you're on quarantine from any topical drops, any medications. Using Diamox as an alternative to topical glaucoma therapies. Hourly preservative-free artificial tears. After 10 days, the surface completely healed. And the question would be, would that happen without the tarsorrhaphy? What came first, the chicken or the egg? Should we have done that first and then the tarsorrhaphy? I'll let you decide, but that was the case of neurotrophic keratitis. The impact of this on quality of life cannot be undersold or underspoken. It's crucial for the healthcare providers to understand and address these aspects when managing patients with neurotrophic keratitis, that this is going to impact their vision, impact their quality of life. And so if we really want to do a better job, we can do a better job for our patients by addressing this and detecting it. And we're going to talk about that. All right, so what is neurotrophic keratitis? Neurotrophic keratitis is this degenerative disease. It's a degeneration of the cornea that affects the cornea, leading to reduction in corneal sensitivity, spontaneous epithelial breakdown, impaired healing. That corneal sensitivity reduction is the key feature in NK and lead to lack awareness of corneal injuries or irritation. That spontaneous breakdown from even the littlest injury or irritation can form persistent epithelial defects, which can also lead to ulcerations. This impaired healing, opens the door for lots of pathogens, microbes, things like that, because the cornea has that inability to detect insult and detect injury, which can lead to further complications, possible vision loss if left untreated. And you'll see that case here. This is one of my frequent flyer neurotrophic patients. You can see the corneal transplant. This is actually transplant number 3 on this gentleman. But really what we're worried about, the big worries here, is corneal ulceration, corneal melting, and corneal perforation. An open eye is not a happy eye. And so we want to do, as eye care providers, everything we can to prevent our patient to getting to this stage. But the hallmark of NK and neurotrophic keratitis is that decrease or absence of corneal sensation, which makes our job a little harder, right? So we delve back into, I think, one of the landmark papers in regards to ocular surface, DEWS 2, which really focused on dry eye. But if we think of that overlying, kind of overreaching category of ocular surface diseases, when we're thinking about neurotrophic disease, where does that fit into the spectrum that DEWS 2 laid out for us? Well, if we think about our neurotrophic patients, we're thinking about asymptomatic or typically asymptomatic, or maybe differently symptomatic than we're used to patients that have these dysfunctional sensations or neurotrophic conditions. So stain without pain is kind of the old phrase there. And if we're talking about feeling and sensation, we have to talk about nerves. And that brings us back to anatomy. So if we think about the corneal anatomy, we're talking about the trigeminal nerve, V1 of the trigeminal nerve that innervates the cornea. These nerve bundles come in temporally and nasally in the protective sheaths, and then they lose the myelin as they come in. And then there's these 2 big nerve plexi in the cornea. We have the subepithelial nerve plexus and then the subbasal nerve plexus. And those are the 2 big areas. We'll see that subbasal nerve plexus is really kind of where all the nerves run across the cornea, and then they reach up with their nerve endings into that subepithelial and intraepithelial nerve plexus, where we have the nerve endings, where we should be sensing insult, injury, infection, dryness, wind, chemicals, all the things that we need to sense, and really remembering that the cornea is the most innervated part of our body, 400 times more nerve endings than our skin, really just nerves everywhere. And so we really should realize that nerves are so important to our cornea. That's why there's such high density of nerves there, is because they're necessary, they're needed. We need to know what's going on. We have to sense dryness. We have to sense injury. Cornea is so important that that's why all those are there. All right, again, trigeminal nerve is responsible for corneal sensation. The nerve bundles at the limbus, the subepithelial nerve plexus, subbaval nerve plexus, and then those sensory terminals where all the sensation and signaling occurs. And I'll stop anatomy at that point. We could delve into that and talk a lot more, but I want you to think about these nerves providing and helping signal homeostasis and neurotrophic supply. So really, homeostasis is really what we want with our cornea when we talk about dry ocular surface disease. We want everything to be in balance. All the nutrients, all the health of the eye, everything should be in balance. And that's really homeostasis. Nerve epithelial interaction. So there's this interaction I want you to also think about between the corneal nerves and the epithelial cells. The epithelial cells, the corneal epithelium, is signaling the nerves. Hey, we need more tears. Hey, it's smoky environment. Hey, I've been damaged. Hey, there's Pseudomonas here trying to eat me. So those epithelial cells are signaling the nerves and telling them what's going on. And then the nerve sends signals to our central nervous system, signals come back, recruitment of inflammation, inflammatory mediators, white blood cells, whatever the case might be. So there's this feedback loop where the nerves are telling the epithelium, hey, you have an abrasion, you need to grow or proliferate. But also the epithelial cells saying, hey, I have an abrasion here, you need to send some help, or you have an infection. So that feedback loop is so important. And if we start thinking about these things a little different way when we're looking at corneas in clinic, hopefully that can help us be better doctors, understand the pathophysiology here. They use neuromediators, substance P, calcineurin, gene-related peptide, and other things to help these signaling pathways occur. And then neurotrophins like nerve growth factor, and we'll talk about corneal nerve growth factor a little bit later. They're essential for survival, maintenance, regeneration of the corneal nerves, as well as promoting epithelial cell proliferation and migration. So again, that feedback loop to keep everyone happy and healthy, maintaining that homeostasis. So what about when things break? What happens when nerves malfunction? Well, that's what happens in neurotrophic keratitis. That's central to neurotrophic keratitis, is impairment of that corneal trigeminal innervation. So we have impairment of the trophic supply and impairment of those trigeminal reflexes, which leads to epithelial breakdown, reduced tear production and blink rate, and impairment of the corneal healing process. And that's neurotrophic keratitis. So why does this happen? What things can cause neurotrophic keratitis? List in your mind or in the chat or on a piece of paper next to you, list 5, 6 things that you think cause neurotrophic keratitis. So, there's different categories. So categorize these things. Hopefully we can expand on your list here a little bit. But some of the ocular causes include herpes simplex, herpes zoster, chemical injuries, other corneal injuries, corneal dystrophies. If we think about some of the big ones, the big corneal dystrophies, granular, and all these other things, those are great too. But even things like keratoconus can have decreased nerve sensation. Fuchs disease has decreased corneal sensation. And even dry eye patients have been shown to have a decreased corneal sensation. So any sort of corneal dystrophy or corneal injury might have some issues, as well as surgical procedures. I think that gets overlooked. We think about that a lot with LASIK patients, but I think we need to think more about other types of surgery, retinal surgeries, posterior chamber surgeries, as well as maybe even orbital surgeries, and of course cataract surgery as well, probably the most common surgery. So central nervous system. So you don't only have nerve endings in your cornea, you have them in your brain and everywhere in between. So central nervous system conditions, diabetes, multiple sclerosis, tumors or compressive lesions might disrupt that neural pathway as well. Parkinson's patients, I see a lot of nerve dysfunction in as well. It affects their blink rate and all those sort of things. And then there's genetic factors, genetic disorders, genetic mutations can affect that. Riley-Day syndrome being a big one. And then medications. So medications, especially the preservatives in our medications, BAK especially, can contribute and help develop NK by causing corneal nerve damage. We'll talk about that a little bit more. But other things that we're putting on our eye, whether it might be preservatives and other things. Yeah, stroke might have a role here as well, right? We're having damage to the central nervous system, and that's going to affect that feedback loop. So anything that might interfere there, that's a great point. So stroke and infarction from other things. And then there's kind of these masqueraders or comorbidities that can happen with neurotrophic keratitis, things that might be related or interrelated, and we need to think about those too. We have things like dry eye disease, contact lens related dry eye, medicamentosa, blepharokeratoconjunctivitis, conjunctivitis, like rosacea blepharoconjunctivitis, eye rubbing like we see in our keratoconic patients, exposure, limbal stem cell deficiency. LCD is limbal stem cell deficiency, and I think that's a big one I see a lot of with our patients is patients with limbal stem cell deficiency having issues with their nerves. So these might be other conditions caused by other things and the other names, but they might have neurotrophic keratitis as a byproduct. They might have it in conjunction. I would challenge you all to check out your limbal stem cell deficient patients next. I think you'll find, in my experience, that they have neurotrophic keratitis the vast majority of the time. I haven't published that or can prove that, but I think if you look, find it. I really haven't heard of any true cases of corneal collagen cross-linking causing neurotrophic keratitis, but keratoconic patients in general will have decreased nerve function. So any procedure you would think might have an increased risk if we're removing epithelium, if we're damaging further cells. So I think it's possible. I haven't seen that a lot, but those patients probably already have nerve dysfunction. To say it's worse afterwards, I haven't seen any studies touching on that. All right. And then the many faces. Another challenge we have is not all these comorbidities, co-conditions of NK, but also the appearance. You know, you see a dendrite and you know that's herpes simplex epithelial keratitis, right? NK looks many different ways in many different patients. Everyone's NK is a little different. They're like snowflakes that we have up here. I know Dr. Kramer doesn't have too many of those in Miami, but we do. And so they're all a little different. You can see this picture from Dr. Hausworth, great friend and colleague, showing this kind of epitheliopathy that's not really staining and taking up stain, but it's almost this microcystic changes in the epithelial. And then for my good friend Clark Chang, who I have lectured on this topic with at AOA and a couple other times, amazing optometrist, you know, they're seeing very severe disease with neovascularization and scarring and post-PK and all these things. So it's quite a spectrum of disease. Here's a couple other faces of NK, if you will. This patient had multiple glaucoma surgeries, had neurotrophic keratitis. So you can see definitely not your typical staining pattern, but this patient had obviously probably some limbal stem cell deficiency as well, but also their corneal sensation was greatly decreased. There is some mapping and some identification of different types of sensations that people have studied in these things. And we'll talk about some of the testing we have available clinically, but there's more in scientific circles and research circles as well. NK, this is patient post-operative medication. So this patient had NK, they came in saying, hey, my vision's blurry. I had surgery and my eye was doing great. Everything was clear. Now it's blurry. And just the post-operative medications overloaded that system and damaged epithelium. So again, this patient came in complaining of vision issues and no pain issues. And that should be a big signal for us. Like, why aren't you complaining about pain? You should be hurting. This cornea should feel uncomfortable. So these are some of the challenges that we see in diagnosing and finding NK. This asymptomatic presentation, patients don't complain about it. Do we address patients when they don't complain about it? I'll let you decide. We just try and give them a new glasses prescription, and do we delve in deeper? Diagnostic anesthetics. Sometimes we put drops in before we see the patient. I say, oh, now I want a chest for corneal sensitivity, but I know your cornea is nerve. So we have to kind of have the patient come back, or it might delay our diagnosis. So something to think about in your clinical flow, and when you're working up patients for screening for NK, can we avoid that? Comorbidities, like we said, patients might have more than, they don't only get to pick one corneal disease, right? Corneal pathology. Patients might have multiple corneal diseases. They might have limbal stem cell deficiency and neurotrophic keratitis. We have to remember that not everything fits into one box, but multiple things might be attacking, injuring, complicating our care of the cornea at one time. And sometimes, things start small, right? So early signs. These patients aren't complaining. We're seeing a little bit of staining. How many times do you see staining in a day? How many patients have early signs of possible NK? So something to think about. These subtle signs might be turning into something bigger in the future. All right, so how do we find these patients? How do we diagnose these patients? We're going to talk about this further, but I just kind of wanted to lay out an outline for you. We'll circle back to this at the end too, but it all starts with our clinical examination, and that starts when we walk in the door, right? We're looking at the patient, seeing the patient, listening to the patient about their symptoms or lack thereof, but also examining the patient as well, assessing the cornea, staining patterns, epithelial defects, location of staining, location of other signs of pathology. And then, of course, corneal sensitivity testing. If inefficiency or inability to sense things in your cornea is the hallmark of NK, well, then we should probably test how sensitive our corneas are. And I know that is kind of newer thinking, and I think it's gaining a lot of traction. We're going to talk a little bit more about there, but there's some instruments we can use. Gaucher-Bonnet aesthesiometer. The Brill has a new aesthesiometer that's a non-contact. We can use things like dental floss and nylon fibers, cotton wool from a Q-tip or a cotton tip applicator to check the sensitivity of the cornea. And then there's another one I'm going to talk about too that maybe you haven't heard of. Confocal microscopy is kind of the next frontier. It's the OCT of the corneal nerve plexi. And so it's in vivo imaging of these corneal nerves. And it's not a very common device that we have, but I really feel like that's the next frontier, hopefully where we're going with diagnosing, imaging, checking for change, hopefully monitoring improvement of corneal nerve density after treatment. There are some classifications and staging criteria that we can use, and those are evolving too. I'm going to keep it simple on those, but you'll see more and more about that. Just as we learn more about this, we have more opportunity to be more specific with classification and diagnosing and saying, hey, this is going to work best for this stage of treatment. All right, so how do you diagnose NK? How do we test nerves? So I kind of went back to my CPR training days here and dug deep and said we should look, listen, and feel. Look, listen, and feel. So look for corneal breakdown. Look for ulcerations. Hope you're not missing too many corneal ulcerations in your clinic. It's in the absence of pain or abnormal sensation. Look for staining. Look for things that are abnormal. Listen. Listen to your patients when they're saying, my vision's blurry, but it doesn't hurt. And not always do patients have no complaints. I think you'll find that patients just have different complaints than you're used to hearing in some of these settings. I hear photophobia or light sensitivity issues in a lot of neurotrophic patients, and that can be very significant. But they might have more photophobic complaints than true like pain, sandy gritty, I feel my eye sort of stuff. And then feel. So how do the patients feel? How do we poke them in the eye? Like, so we're going to test their sensations. So we're going to poke them or puff them, see how they feel. And then of course, confocal microscopy being a way to image those nerves. There's a few out there. I don't have any recommendations for places to get one. I'm going to try and stay away from recommendations in that sort of setting, but there's a few out there. How do you diagnose MK? Again, so the crochet bonnet is here on that image. This is this device that holds this long nylon thread. And when we're extended, when we're out at 6, the thread, the nylon monofilament is very soft. When we shorten that thread down to 1, it's very stiff and very hard. So it controls how we touch the eye. There's gas or non-contact anesthesiometers, cotton wool tests, dental floss, and then the administration of hypertonic saline solution. Who knows what hypertonic saline is? Well, you might call it Muro 128. Been out on the market for a long time, but that's 5% hypertonic solution. And there was this article published in 1994, I believe it was. It's underneath 93. Sorry, August of 93, that showed hypertonic saline and installation of that, and the lack of sensation from putting salt in your eye can be used as a diagnostic criteria for NK. They used this in patients with trigeminal acoustic neuromas that had trigeminal damage from repair of acoustic neuromas, and said, yeah, normal patients can feel the saline, and these patients can't, neurotrophic patients can't. Could also maybe use that for the other side of the spectrum, where patients are hypersensitive, have neuropathic eye pain. They'll overreact to salt in their eyes, overreact to a Q-tip in their eyes. Again, when we're testing these things, I always like I want the clinician to be thinking about this as testing reflexes, right? We're testing nerves. So when you go in and you get the old hammer to the knee and the knee jerks, or you do the Babinski test on the bottom of the foot, that's a nerve reaction, that's a reflex. And so we're testing for corneal reflex. These patients, you don't have to tell a patient, you're going to feel something on your knee and you might want to kick. They're going to kick. And so when we're touching the cornea, they're going to want to blink. And so we really don't have to explain it too much other than relax, look straight ahead, and I'm going to be doing some things over here. You don't have to tell them they might blink or things like that. Really think of it like a reflex. And so you're looking for that reflexive response, because anytime you poke anyone in the eye, they should want to protect the eye and protect that. There is some overlap between these neurotrophic patients and severe dry eye patients. Like we said, that might be a comorbidity or something that overlaps. Again, just maybe think about, if you're not comfortable poking people in the eye, maybe using this drop, and a little something different maybe you haven't heard of with regards to testing for corneal sensitivity. But back to our clinical cases. Here's a beautiful cornea again, a different staining pattern than maybe you're used to seeing. 69-year-old female, dry eye consult, here for blurry vision. Chief complaint, blurry vision. Again, the red flags should go up. Ocular history, LASIK, cataract surgery, non-proliferative diabetic retinopathy, and dry eye disease. So thinking about risk factors, things that might cause neurotrophic, I think you've got 4 right there, right? Including dry eye disease, like one of the questions mentioned. Medical history, again, diabetes, anxiety, hypertension, heart disease, sleep apnea, thyroid cancer, obesity, smoker. So all these things might cause some issues. And then we see this, another part of the cornea, seeing that haze. Patients using genteel moderate 4 to 6 times a day without improvement. Restasis once or twice a day. Again, seeing irregular epithelium, things aren't adding up. The mammography doesn't look perfect, but it doesn't look horrible. Lipid layer thickness looks pretty good. VA is 2100. Well, they're right. Their vision's blurry, right? Speed, 10 out of 28. So there's symptoms. There's some symptoms, right? Are they what we'd expect for a 2100 eye with a severe corneal staining? Osmolarity is slightly elevated. Tear lab inflammatory is negative. Just giving you some pieces to think about things as clinicians, as you all are, or many of you are. And then I wanted to touch on this slide a little bit, staining. So when we talk about staining, we really want to think about the where and the why. Why is that there? Why is it staining there? Location and appearance are so important. We saw those pictures from Dr. Hauswirth where it really wasn't staining. There's definitely some epitheliopathy going on. Should give us some signals that something's not right here. Spidey sense tingling. Inferior corneal staining, more typical with dry eye. Conjunctival staining, more typical with dry eye. But NK tends to have more central staining. So this diffuse staining, more central staining, should give us some highlights here. All right, herpetic eye disease and neurotrophic keratitis, something we definitely have to talk about. Viral latency, so this virus is living in our trigeminal ganglia. It can become reactivated, and when it reactivates and comes down that, it can impair nerve function, innervation, neurotrophic support, and lead to development of NK. Again, here in herpetic eye disease, about a third of NK cases in this study were related to herpetic origins, whether that's zoster or simplex. You can see 25% of patients, 26% of patients with simplex, 6.5 with zoster. Again, listing those other causes, iatrogenic from vitrectomy and all sorts of things, trachoma, but viruses, specifically simplex virus, being the main cause for a lot of our neurotrophic cases. All right, again, corneal sensitivity is an easy thing to do. Our ocular symptoms, our signs should raise our red flags, our spidey sense when we're seeing 2100 vision, lots of corneal staining, and not a lot of complaints. That should lead you to test corneal sensitivity. And you can test corneal sensitivity qualitatively by touching the cornea, and quantitative with some aesthesiometers. And then that there is a spectrum of disease, right? There's a spectrum of disease. They might have mild decrease, they might have very severe decrease in their corneal sensitivity. And that can be monocular, binocular. I wanted to show you this little video showing how we test corneal sensation. Let's play that again. We're coming in, testing for that reflex, that reflexive response, that when something is touching your cornea, you should feel it. Again, we're studying long, and then we'll want to decrease it if you're using the Cochet-Bonnet. And you can test different quadrants. A lot of people will just do central for speed and ease, but some patients, especially patients with viral disease, will have decrease in the area where they've had dendritic attacks, and then normal sensation in other parts of the cornea. So we can be quadrant specific, just like we measure staining inferior, superior, central. We can do that with corneal sensation as well. And then right and left, important. There should be symmetry between the eyes. And that's a good way to test if you're using a cotton wisp or dental floss, is testing the normal eye first and then moving over to the suspected eye. So always remember that. This is a new device by Brill. That's a non-contact aesthesiometer. It uses a puff of air and has different settings. This is a new thing you might hear about, so I wanted to give you just a little intro to it, let you explore it further. But it has different settings, and if you can sense level 1, well, that you shouldn't be able to sense that. They're saying at level 1, that may be actually hypersensitive corneas, and then regular sensation, all the way up to very severe corneal sensation, a big puff of air and no response, no reflex. That wouldn't, you can target this. From what I've seen, I haven't done this specifically, but from what I've read, you can target different areas with this device. It produces a puff of air and it can be aimed. We'll talk about that here. But puffs of air with different intensities, and to find the correct distance and location, it has a camera electronic positioning system. This is from some of their research, but it's attached to a slit lamp. and then the lowest puff or the lowest sensation is recorded. If you went through all 5 and they had no sensation, that would be the maximum value, say the maximum neurotrophic disease. This is another picture of it kind of attaching to a slit lamp. So you can target different areas on the cornea, from what I've heard. All right, again, corneal aesthesiometry, the measurement of corneal sensation. We have that Cochet-Bonnet with the nylon monofilament. Been around for a long time, but we can do even things like Neuro 128, cotton wool from a Q-tip applicator, and then there's some new technologies coming. There are other things that are being used too. There's other devices in more research settings that are using chemical stimulants to the cornea for checking response, temperature. Again, we have all these different corneal nerve sensations, sensors, heat and cold, chemical insult, pressure or mechanical, which is what we're testing here. And so there are different sensors out there and different things, and we can test for different things in different ways. And we're exploring those mostly in research centers and other things. But something you should think about when we're thinking about how the cornea senses things is not just pressure or touch, but there's other ways and other nerves that get stimulated. Other different types of nociceptors or nerves. Again, confocal microscopy. Just wanted to show you some pictures here. This one picture with a nice long skinny nerves is that normal subbasal nerve cornea, and then you can see decreased nerve anatomy in that subbasal nerve plexus in patients that have neurotrophic keratitis. So hopefully this resonates as the OCT image of the corneal nerve plexus. And wouldn't it be great if we could just image all those? It doesn't tell us the whole story, right? It doesn't tell us how those nerves go back, what happens behind the cornea, but at least it would give us some indication of what's going on inside the cornea. Confocal microscopy, again, non-invasive imaging technique would be kind of the next step, next generation of ways of imaging corneal nerves. And we're not great at that. Just think of the evolution of OCTs. Now we have all this data on, paramacular nerve or paramacular nerve fiber layer thickness and all this stuff that's came along. Wouldn't it be great if we had some more stuff like that in our option, in our hands, in our clinics? Classification, I wanted to touch on this briefly too, because you might hear about it. The most common talked about classification is the Mackey neurotrophic keratitis classification, and it was used in the clinical trials for Synedromin, human corneal nerve growth factor supplement. So stage 1 is kind of mild epithelial alterations, but no true epithelial defect. Stage 2, moderate, persistent epithelial defects, like we saw in our first case, and right away, no stromal ulceration, so no stromal involvement. We'll still kind of basement membrane and forward, but the epithelium is the inability to heal, or it's coalesced also epithelial defect. And then stage 3, where we're losing the war here. We're getting stromal thinning, melting, perforation. So if we're seeing stromal thinning, corneal thinning in that area, this is kind of a gross grading scale, but something that's been used in clinical research and something you can use to document the stage of neurotrophic keratitis. Again, there'll probably be more of these in the future and an evolution of those. So again, just circling back to the summary here, diagnosing neurotrophic keratitis isn't always the easiest thing. So it's my challenge to you all to go out and find it early, find it often. Talk to your patients about nerve function and the health of their corneas, and what sort of things could cause nerve dysfunction, surgeries, preservatives, all these things. But diagnosing it through that thorough clinical exam, look, listen, and feel, testing with cotton wisp or dental floss or some fancy aesthesiometer that you stole from the local university. Hopefully not. But next generation of confocal microscopy being that next generation of actual diagnosing corneal nerve anatomy in our plexi. And then we do have that opportunity to stage it or classify it. Now we found it. what are we going to do about it, right? How do we treat neurotrophic keratitis? Well, there's a lot of options. It depends on what's going on. But what are our goals? What are the goals of treatment? How do you pick? Well, I think our treatment options should steer towards our goals. And goal number one being to promote corneal healing. We don't want corneal perforation. We don't want our patient to have 3 emergent corneal transplants. So we want to promote corneal healing early and often. We want to get that cornea healed. We want to facilitate epithelial growth, proliferation, and prevent breakdown. We want to restore corneal sensitivity. We would love to increase nerve function and help that interrelation between the epithelium and those corneal nerves, right? That feedback loop needs to be restored. We have to think about how can we do that. We want to obviously prevent complications, avoid corneal melting, avoid corneal perforation, avoid scarring, and keep and maintain patient's vision. So we want to keep those visual outcomes as good as possible, preserve vision, improve the patient's quality of life by doing that. So those are our goals, right? So how do we achieve those goals? Well, there's a lot of options. I think you'll say, anything that might help epithelium be healthier, whether that might be non-preservative artificial tears, to a scleral lens, to a tarsorrhaphy, to gluing a perforated cornea or a desmetocele. So anything we can do. There's a huge spectrum of NK treatments, and we've kind of been reaching, for generations, we've been throwing the kitchen sink at this and doing everything we can. I do believe that, we shouldn't always rush in with guns blazing, especially in early disease. We want to treat to the appropriate level of the pathology. But all these things, plugs, tears, doxycycline, tarsorrhaphies, corneal neurotinization surgeries, all these things have our options for our patients. And I'd be remiss if I didn't mention scleral lenses at least a couple times by providing a healthy environment underneath which cornea can restore itself. Again, this tends to be a progressive condition, so we should think about stepping a game up and getting more aggressive depending on the condition. Question, I wouldn't consider a corneal Delin NK unless there was decreased nerve function as well. Delin, I tend to think of it like dehydration of an area of cornea. The epithelium is just dehydrating and the stroma might be dehydrating as well. But I don't think it's definitive but again, might be one of those comorbidities. Why is that patient having dehydration? Is there incomplete lid function? Is there incomplete sensation? So I think of those as separate, but definitely probably worth testing for nerve function in those patients to see if there's more than one thing going on, right? More than one pathology. Autologous serum eye drops are a great option for many of our neurotrophic keratitis patients. Have been used for a long time now, but we're essentially harnessing the healing powers of our blood. Our tear film, our ocular surface tear film, is supposed to supply neurotrophins and growth factors and things like that to our corneal epithelium as well, nutrients. And if those aren't being supplied, maybe we can supplement them by some of the growth factors and things in our blood that might spur healing and things like that. So this has been documented to help with NK, usually dosed 6 to 8 times a day for the first month, tapering to QID as things improve. We tend to use 20. I tend to use 30% as a starting point. A lot of the research done around autologous serum is around 20% of patients, but it can be as high as 100% for different sort of pathologies. But in general, I tend to use 30, 20% still on a lot in the research. Again, what this entails is drawing the patient's blood, centrifuging it, removing the serum portion, and then diluting that typically with balanced salt solution, and freezing it, refrigerating it until it's used up, typically dosed 6 to 8 times a day. Amniotic membranes might be another option. We talked about this at the beginning, but cryopreserved versus dehydrated. One study showed 75% of patients with NK achieved reepithelialization in about 16 days. Average time of reepithelialization being about 21 days. So this isn't going to be healed in a day, right? This isn't the corneal abrasion that happened out in the yard over Memorial Day weekend that is going to heal in a day or two. These are slow healing, sick corneas that are going to take some time. So be patient is another side of that. If you're seeing improvement, you're headed in the right direction. I don't think you have to, if you're seeing improvement, just stay the course. Don't get too worried, but be cautious and careful because these are delicate corneas and can be sick eyes that can go south quickly. Scleral lenses. Alan Kwok, one of my mentors, case he showed here with this neurotrophic keratitis that really restructured, reepithelialized, and the cornea restructured. I would say that there's collagen that's restructuring keratocytes are helping heal over time here, just with giving it the right environment. All right, surgical treatments. Well, there are some surgeries. They're kind of newer things, but we're actually, talking about taking tarsorrhaphy being a surgical option. It works for the most part, but it has other effects. It changes our blink function and blink rate or cosmesis. But lateral tarsorrhaphy is definitely an option, and reversible tarsorrhaphies. Botox tarsorrhaphy is an option too. We can drop that levator with some Botox and get some good results by inducing that ptosis as well. Conjunctival flaps to cover cornea that won't heal. They usually leave on amniotics as long as they'll stay until they dissolve, but sometimes if the epithelium hasn't healed yet, you'll have to put another one on or move to another form of treatment, whether that be a scleral lens or a standard bandage lens or something like that. So you have to keep going until you get that full reepithelialization, and then sometimes even after too, right? So you'll heal a cornea and then they break down again. And so that's the vicious cycle of NK a lot of times, is treat them till they heal, poke the bear and see if they can hang in on their own. And sometimes they can't. And then you have to go back to the drawing board and be more aggressive next time. Neurotonization is a surgery where we can take nerve from the fellow eye and put it in this eye from donor nerve tissue and integrate the trigeminal nerve where it might be functioning. Usually they'll go into the frontal nerve here and come down, but just using cadaver nerve or nerve from the leg to induce nerve function and nerve growth. And it's been shown to be helpful. There's also Synedrimen. So in 2018, Synedrimen was approved for neurotrophic keratitis. And this is a structurally identical molecule to human nerve growth factor protein. It's found, which is found in corneal tissue. So it's this natural occurring neurotrophin, or it's identical to naturally occurring neurotrophin that's responsible for differentiation, growth, and maintenance of neurons. And so we can use that in drop form onto the cornea and help restore our epithelial integrity. There's a little data from that. So these are the interesting thing about these clinical trials with Synedrimen was these are patients that failed everything else. These are patients that failed tears, they failed steroids, they failed plugs, they failed everything else. And then they were put into a study where they were given Synedrimen every 2 hours for 6 times a day. So 6 drops in a day every 2 hours. And 80% of those patients who had achieved complete corneal healing. So 80% of patients completely healed. It's pretty impressive. And we're still healed at 48 weeks after one 8-week cycle. So pretty impressive results from the clinical trials. I'd recommend you all delve into it deeper. Again, 80% of patients who achieved complete corneal healing stayed healed at 48 weeks. So about a year later, they're still healed. So 80% of patients that healed on Synedrimen stayed healed even up to a year after 48 weeks after stopping the treatment. Question is, why isn't Synedrimen put in a normal dropper? It is kind of complicated system to get it out, but because it's a very complicated molecule, and I'm sure they're working on making it more deliverable to patients, and hopefully it will be in the future. But the company's done a great job of getting this really high-tech molecule into our hands and into our patients' eyes. So hopefully there'll be advancements in delivery systems in the future, and I'm sure they're working on that. This is some newer data. So this is a phase 4. This is after release. This is called the Defendo trial. This was for NK stage 1. So these were milder cases, patients that we didn't have persistent epithelial defects, but at least grade 3 corneal staining and decreased corneal sensation, less than or equal to 4 millimeters on Cochet-Bonnet. Again, 6 or higher be normal, but it only goes up to 6. So at 8 weeks, no corneal staining or other abnormalities, as per the reading center, where it was their endpoint. And they found that a lot of patients, 84.5% of their patients, met that endpoint. So 84.5% of patients met the study endpoint of no staining. So resolved their corneal staining was grade 3 or worse. Synedgermin is approved for all stages of neurotrophic keratitis, stage 1, 2, or 3. What about the use in bandaged lenses? I get asked this question a lot, so I'm beating you to the punch. But what about the use of Synedgermin in the presence of bandaged contact lenses? One of the things we use so much in clinic. So there's one paper out there, is just kind of a case series, 18 eyes retrospective review. And they found that 67% of eyes with complete epithelial defect resolution and remaining, 33 did show a reduction of epithelial defect size reduction, and the remaining 33%. And this is when using a contact lens and Synedgermin in combination. They found a higher rate of healed epithelial defects in small diameter bandage lenses, but a higher mean number of quadrants of post-treatment corneal sensation increase in larger diameter bandage contact lenses. I don't know what that means yet. I don't know if we do yet, but that was just one of their outcomes, one of their findings. Conclusion here of this article being, in eyes demonstrating previous ocular surface decompensation with discontinuation of a bandage lens, so breakdown after you take the lens off, maintenance of the bandage lens using treatment of Synedgermin may be considered. So I'll leave that up to you, but there is a little data out there about that, and hopefully more to come in the future with combination therapy, because like we said, we have to sometimes step up our game when they're breaking down again and again and again, and using the next level of treatment for those patients is an important consideration in neurotrophic disease. All right, we're going to wrap it up quick here, but this is again that case I wanted to touch on. This patient had cyclosporin, Procare in the left eye, and then the right eye. That was that 2100 eye. And after 5 weeks of Synedgermin, this is their cornea, and the vision was 20/40. All right. One more thing I wanted to touch on is prevention. An ounce of prevention is a pound of cure. And in the definition of dry eye and ocular surface disease, we have this neurogenic considerations. So we know that BAK exposure can cause neurotrophic keratitis. I'm just going to flip through these quickly because we're wrapping up. But we know those things might cause that. So if you are prescribing drops with BAK, please know that you may be causing neurotrophic trouble in the future. And so think about that. Next horizons in neurostimulation. Other things are out there. Other things are coming. Things like stimulating TRP receptors or some of these nociceptors in our cornea. Naltrexone might be found to help diabetic type corneal sensation or issues.